follow this paradigm that we use. And so, hopefully this will be meaningful for everybody. I think what we've done really since the inception of trying to figure out how to deal with these tumors in a meaningful way was use what's called this GNOMES pathway, this GNOMES framework. And I'll try to share with you how that works and what's really important for you as you integrate this into your practices, and then really what you need to know to assess to get this pathway initiated. Metastatic spine tumors are a massive problem. 20% of cancer patients will develop spine metastases over the course of their illness. And we've seen an increased number of metastatic spine tumors. Part of it is just an ascertainment issue that MR and FDG-PAD have improved detection, but also these newer systemic treatments of biologics and checkpoint inhibitors have improved survivals. But it turns out that these newer systemic agents are much more effective for visceral than for bone disease. So we think we're going to see a continued uptick in the number of tumors that we're responsible for. Despite this improved survival in this patient population, the treatment of metastatic disease remains palliative. We want to improve or maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, and ultimately improve quality of life. And if we get this outcome of a patient who was operated for a thoracolumbar burst fracture, who 3 months after surgery is doing this 100-mile paddle on a river in Pennsylvania, we've really done exactly what we were supposed to do versus this patient who not only failed fixation, his screws pulled out here, and you can see this sort of swan neck deformity, but he also had a radiation recall burn on his back, requiring extension of his hardware, both superior and inferior. So we extended all the way up to C2. And then this is actually a free flap closure of this wound. And in the primary bone tumors, this is a really bad outcome, but sort of acceptable in the context of treating primary tumors like chordoma or chondrosarcoma, although I think that's changing now too. But certainly the metastatic patients, this is completely unforgivable. The thing that's changed everything for us is really not on the surgical side, but the integration evolution of what's called stereotactic radiosurgery. It's defined as high dose perfection conformal radiation, often given a 16 to 24 gray single fraction, so just one dose of radiation, or 8 to 10 gray times 3 fractions. And compared to conventional external beam radiation, which is often given as 3 gray times 10 fractions, radiosurgery obviously has a shorter treatment time, but we can actually give an ablative cytotoxic tumoral dose. And that fundamentally changed our treatment paradigms, including the indications for and type of surgery that we do. There have been major advances in this radiosurgery technology. Some of it's technological, but we also define tumoricidal doses and dose constraints for organs at risk, and even define the radiobiology of radiosurgery. When we started the concept and started to integrate radiosurgery, it was very clear at Memorial that we couldn't work in a vacuum. We couldn't have a surgeon in one place, a radiation oncologist in another, and an interventional radiologist in a third, and try to coordinate patient care in a meaningful way. And so we put together this multidisciplinary spine tumor center or service. And it started out with 3 of us. It was myself, Josh Yamada, who is really the father and pioneer of most of the data and outcomes with radiosurgery. And then Eric Liss is the best reader in the world, but he's also a superb interventionalist who does a lot of kyphovertebroplasty and biopsies. And we realized that we had to go to clinic together. We couldn't have a patient come in who needed radiation or surgery and have them see the wrong person and wait 3 weeks to get that disposition. In colon cancer or breast, you can wait a while to get treatment, but if you wait even a month in some of these tumors like prostate, they will upstage, and all of a sudden something that was a radiation target you have to operate on. And so we put everybody into the same clinic and then completely integrated. As we grew out into the networks, the enterprise got fairly, what is really massive at this point. We have 3 surgeons here, as you all know. Ori Barzilai, who's been here about 6 years and is just a superb at everything, but he does a lot of the minimally invasive interventions. And then Chris Newman just joined us, who has a lot of both clinical and basic science interests, and just a superb addition. And then in radiation oncology, you can see what happened, how important radiosurgery is in the treatment. We now have a little over 20 radiation oncologists who not only do spine radiosurgery, but come to tumor board every week and are really vibrantly part of this program and really a meaningful integration We added pain anesthesia. Predominantly, Amit Gulati really drives the innovations in that domain, and then Lisa Rupert is musculoskeletal and spine rehab medicine, and become really a focal point of a lot of what we do in clinic goes through her, because she's so good at sort of siphoning out the issues that really are inherent and important in what we do. If you look at the radiosurgery numbers, the radiation numbers, we did almost 400 targets in 2019. That makes us 10 times bigger than any program in the country. The surgery, you can see it's about, a fifth of what we do is actually surgical. So while we traditionally people think of spine tumors as being surgical, really the focal point of treatment is radiation, and everything sort of integrates around that. What's important for APPs particularly, because you oftentimes are going to be the gatekeepers for whether we go to imaging and potentially even how quickly they need to go to surgery. And I think what's most important is to really recognize the pain syndromes that they present with and what that actually means. So there are three predominant pain syndromes. We call it biologic, mechanical, and radiculopathy, and then the development of myelopathy or spinal cord compression, and all of them have significant treatment implications. Biologic pain is far and away the most common presenting symptom of a patient with tumor. And basically, it's night or morning pain that resolves over the course of the day. So they're fine all day. They go to bed at night. They wake up in the middle of the night and they have searing pain. And if they get up at night to make it go away, they have to walk around for an hour or two before it gets better. Or they get up in the morning, and again, it takes an hour or two for that to resolve. What happens with cancer or any inflammatory pathology is that when you go to bed at night, you stop making steroids. Your adrenal gland shuts down, so you can go to sleep. And so you get flare inflammatory pain from mediators secreted by the tumor. When you get up and start walking, your adrenal gland kicks back and you feel better. And this is why we give exogenous steroids, right? Why we give Decadron for pain, because it's the best anti-inflammatory in the world. And all tumors that grow active or malignant create a massive amount of inflammation, with rare exceptions. So if you're ever with us and when we go to see a patient at the bedside and they say they have pain, the first question we say is it night or morning pain, right? Is it biologic pain? Because when you hear this biologic pain, depending on the imaging, the high likelihood is that you can send them to radiation and that pain will get better. That's in counter-distinction to what we call mechanical pain, which is not night or morning pain that resolves over the course of the day, but it's purely movement-related pain. It's very level dependent. So in the very high cervical spine, they'll have flexion extension pain. They don't want to look up or down. But what's really characteristic is they won't look side to side. They can't turn their head because all the rotation in the cervical spine occurs at that C1-2 junction. So if you see a person who won't turn their head, there's a very high probability they have C1, C2 pathology, and a third of them will have occipital neuralgia, pain going up the back of their head from compression of the C2 nerve root. In the subaxial cervical spine, they hurt in flexion extension, looking up and down. But if they're grossly unstable, they'll be chin on chest. And if you ask them to look up, they'll actually take their hands and push their head back. That's gross instability in the cervical spine from a clinical standpoint. Thoracic spine is sort of counterintuitive because we always think of mechanical pain as axial load, standing, sitting pain. Thoracolumbar junction or thoracic spine, patients are very comfortable in kyphosis. So they want to sit up or stand because they can put themselves forward, right? They can do this. The problem with these patients is they're hinging on an unstable kyphosis. So what they don't want to do is lie recumbent. They don't want to flatten that kyphosis because unlike a osteoporotic who sort of moves like that in that kyphotic position, these people, when they lie down, they're actually flipping that spine back. And if they stand up, they have to flip it back into position. So I always say, if you hear that somebody's sitting in a recliner at night that they won't get flat in bed because they're afraid this back pain will be exacerbated, there's a very high probability that they're unstable. And then finally, in the lumbar spine, we see a lot of axial load pain, sitting, standing pain that causes severe back pain, and that is an instability characteristic. There's a thing called mechanical radiculopathy, which is axial load pain, sitting or standing, that causes severe back and leg pain, and that's gross instability to us too. We'll talk about it in a minute. The SIN score was developed to define instability in the neoplastic setting. And once it's defined, patients are often candidates for open surgery, but very often thoracic lumbar spine cement augmentation. And then we do now use percutaneous pedicle screws. And I'll talk about that in a minute. Radiculopathy is different, right? So you have these back pain. The other pain that patients get with spine metastases is radiculopathy, which is nerve root pain. Very often we think that other than mechanical radiculopathy, that once they start to develop radicular symptoms anywhere in the spinal axis, that it's not usually bony compression, but it's usually soft tissue now growing out of the bone and compressing the nerve root. The problem with radiculopathy is it looks like lots of other pathologies, right? So you can have L3 radiculopathy runs from the lateral thigh to the medial knee, and it, for all the world, a femur fracture does the same thing, right? It hurts in the femur. And then you have all these patients who have pain running down the lateral aspect of the leg. And that's not radiculopathy, but a lot of patients come in thinking that it is, but they'll have iliotibial band or lateral cutaneous nerve of the thigh. And so you have to siphon that out and actually lay hands on them. L2 goes to the groin. What else goes to the groin? Right, hip pathology. So you have to be able to rotate their hip and figure out whether this is L2 or a hip fracture. And you really do have to lay hands on these patients. You have to be able to rotate their hip and make sure. And a lot of these patients too will have tandem lesions, right? They'll have L2 compression and a hip fracture, and you need to figure out what that is. I think neuropathy, everybody's pretty good at siphoning out from radiculopathy, but certainly it can be confusing on occasion. Then we see a lot of brachial sacral plexus tumors, which look like radiculopathy, and then obviously leptomeningeal tumor. Once you get that epidural disease, oftentimes, if there's no compression, we can do radiation, but it's very dependent on both the tumor histology and the degree of cord compression, what we ultimately do, even in patients who present with radiculopathy only. And then myelopathy, right? Signs of spinal cord compression. Anytime you have spinal cord compression signs, you know that radiographically they have high-grade cord compression. The spinothalamic tracts are often injured first, and that's because oftentimes I think they're incredibly sensitive to compression, but most tumor will grow up from the bone and then compress posteriorly, and the spinothalamic tracts are in the anterior part of the spinal cord. So often people will get numb before they lose motor, and you want to pick them up as early as you can, because whatever treatment we offer, the better they are neurologically coming in, the better chance we have of neurologic recovery coming out, or a good neurologic outcome. Motor is loss of corticospinal tracts. Proprioception is in the back part of the spine. And even when we have very high grade cord compression from the posterior elements compressing from the back forward, it's a very late finding in myelopathy. Those fibers are pretty hardy, and they really can take significant compression before we start to lose. And the problem with losing proprioception in an adult is it's as bad as being weak or paralyzed. If they cannot feel where their feet are in space, they can't walk. Now, Lisa's done a great job with things like textured insoles, which give them some feedback when they're walking. So there are some mechanisms, but losing proprioception is a big deal for cancer patients. And then autonomic bowel and bladder, there are no less than 1 million things that impact bowel and bladder, inpatient, outpatient, whether it's narcotics or prostatic hypertrophy or you name it. The question is, how do you differentiate a neurogenic cause, a neural cause, versus all these other issues? And the cheap and easy one, short of doing a rectal on every patient that comes in, et cetera, is the first question we ask always is, are you numb in your perineum, in your private area, saddle anesthesia? Because the motor and sensory have to go together. So if you're not numb in your perineum, the high likelihood is that the cause is other. The second issue is that it's like loss of proprioception, it's a very, very, very late finding in myelopathy. So there's sacral sparing virtually all the way down to the conus. So unless you have high-grade cord compression at the conus or bilateral replacement of S234 in the sacrum, bowel bladder loss is never in isolation. Basically, you have to be paralyzed before you lose bowel and bladder. And so if you have a conus lesion or really significant disease in the sacrum, you might lose it in isolation. but typically anywhere else in the spine, if you have a T7 lesion, high-grade cord compression, they have bowel and bladder issues and they're not paralyzed, it's probably not coming from there. And that may just help you siphon it out. But the first question you always want to ask is, are you numbing your perineum? And that will usually give you a pretty good sense of what's going on. In terms of imaging, we use everything, but basically we're dependent on MR because it's the most sensitive and specific for both bone and soft tissues. And when you're screening a patient, we really like to get whole spinal axis imaging. And I sort of liken it to, you would never image part of the liver and then send them back for the other part. And when you're trying to make decisions about radiation or surgery, you really need to know what the whole spinal axis shows. What we're looking for typically is hypointensity darkness on the T1 weighted images relative to normal marrow, or we use the stir images where the tumor lights up like a Christmas tree. This is a fat suppressed T2 image. And so we screen the whole spine. We want to know where the tumor is. We usually look at the T1 weighted without contrast and the stir images. In terms of determining the degree of spinal cord compression, we really like the T2 weighted images because there's a myelogram effect. And so you can very easily see compression of this and the spinal cord on T2. And then we use a T1 post contrast. We get a lot of pushback for using contrast in these patients, but it's important, particularly if patients have instrumentation. It's much easier to see the T1 post contrast. T2 often has a lot of artifacts, so we really can't tell nearly as well. The other reason we give contrast is because oftentimes patients, especially when they have neurologic issues, have not epidural disease, but they have leptomeningeal tumor. It's surprising how many times people come with a neurologic injury and you get a whole screen without contrast and you see virtually nothing. And then you give the contrast and you can see that light up. And then occasionally we'll see an intramedullary in the spinal cord metastases as well. This was an example of a patient who came in to clinic. We argue all the time for doing full sequence imaging with contrast when they come through UCC. Unfortunately, the rapid response team does not give contrast because we're just trying to rule out surgical pathology in those patients. But here's a 67-year-old with non-small, had acute onset of weakness, bilateral extremity weakness. It was really an ASIS 3 out of 5 lower extremities and had a pin level at T6. If you just look at the T1, maybe it gets a little crowded here, but it's a little hard to tell. This, I can't tell what's going on, but there's definitely something wrong. And then it's not really until you give the contrast that you can see the leptomeningeal tumor. Here's another example of a patient with leiomyosarcoma. It is extraordinarily rare for an epidural or big paraspinal tumor to actually evade into the spinal, into the intradural space. And you can see here, this looks like it's epidural compression. It sort of has this V sign coming around. It wasn't until we gave contrast that we could actually see that the tumor actually eroded through the dura and was against the spinal cord. So we think contrast in general is really important for these patients. The other thing, especially pre-treatment, it's important to get what's called a DCE image, dynamic contrast enhanced image, particularly looking at plasma volume. So when you irradiate a patient like this is a renal cell carcinoma that was irradiated, and you can see the soft tissue sort of component resolve, but you still are left with residual ghost in the bone, and we're never sure whether this is treated tumor or not. PET scan's somewhat helpful, but they usually turn sort of lukewarm and you're never quite sure. But the DCE image is very sensitive for detecting whether there's viable tumor in this. And that takes contrast. It's just a contrast bolus and it's acquired in different ways. And when you look at the plasma volume, you can very easily see, even before you see radiographic changes or with this radiographic residual, whether you have viable residual tumor or not. If at Memorial, I'm not sure what they're doing at Cornell, but at Memorial, at the very end of the sequencing, they usually have the plasma, they'll have the DCE images. There's a K-trans and a plasma volume. The only one we're really interested in is the plasma volume. But you can see here, this is really a computer generated sort of fancy model. The ones that we see that are done for us by technicians are just black. They're normal MR, and then orange or yellow is sort of the color scheme. But you can see here this tumor and then completely resolved on DCE images. And you can see that DCE plasma volume fall out within an hour of radiosurgery treatment, which really suggests a great treatment response. So we have already operated on somebody, they've gotten radiation, they come in with recurrent pain or neurologic symptoms. And what imaging do we need to get? And we would basically say on every single patient, we need an MR, right, to see whether they have progressive tumor like this patient. So they were irradiated and then they came in with progressive neurologic symptoms. We need the MR to see whether they have progressive symptoms of cord compression. And if they have hardware with progressive pain or potentially even a neurologic injury, we need to get either plain X-rays or a CT of the spine to see what happened to the hardware. And here, with these cement augmented screws, we started to see some caps back out at long-term follow-up, and that's in point of fact what happened. So this screw rod became disconnected from this screw. And so the two images you want to know, if people come in with new symptoms post-radiation or surgery, you want an MR and you want plain X-rays or a CT. So here's a typical example that we see, on a daily basis. 66-year-old male, history of renal cell carcinoma, has this 3-week history of this night or morning pain that resolves over the course of the day, but it was bad. Acute onset of weakness, Asia sees less than 3 out of 5 in lower extremities. He has other medical issues, chronic renal insufficiency. Systemic workup showed renal cell extending into the renal vein and some pulmonary nodules. And you can see this is the spinal cord, is this little diamond here. And you can see this really high-grade circumferential epidural disease at T10. When I got to Memorial, I hate to say, exactly 30 years ago, we'd look at a patient like that and had no idea how to make decisions about them. They were sick, they had neurologic issues, they were in pain. And so we wanted to come up with a mechanism to evaluate these patients, and that became known as GNOMES, neurologic, oncologic, mechanical stability, and systemic disease, to decide best treatment. It is a decision framework, and it's largely left as a decision framework rather than an algorithm, because as we get new technologies or evidence-based medicine, we plug it into the GNOMES framework. We don't want to change those 4 sentinel decision points, but the decisions that we make on them are significantly different in 2022 than they were when we started this in 1995. Why? In part because there's so many other active agents. So when we started, we had really limited chemotherapy for systemic options. We had sort of limited photon beam, conventional external beam radiation, and then limited surgical options. And this is what's happened over the last, really 10 years has been the major advances. And we had to figure out how to integrate all these new technologies that are really meaningful in the treatment of these patients in terms of improving outcomes. So in terms of GNOMES, the neurologic and oncologic considerations are made in combination. From a neurologic perspective, we're very concerned about myelopathy and functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression, and this scoring system has been validated. And on the reports at MSK, you will always see on the ESC, they'll have an ESCC score. That's what this is. And what it does is it prompts you, if you have minimal compression, there's not quite the same urgency as if they have high grades. So the scoring system is 0, is really just bone only. There's something in the middle of the bone with no epidural disease. 1A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression, CSF seen. 3 spinal cord compression, no CSF seen. And for decision-making purposes, typically the 2s and 3s are considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control. Local tumor control, at least to us, is completely predicated on the radiation response, and radiosensitivity of tumor histology has been completely redefined as we've transitioned from this conventional external beam radiation, 30 gray and 10 fractions, to a radiosurgery, 24 gray single fraction, or 30 gray and 3 fractions. We have other mechanisms to treat with radiation. We do intraoperative brachytherapy, P32, to clear dural margins, and high-dose radium afterloaded catheters for recurrent bone disease. We go back to that mechanical instability. Why? Because no amount of radiation will stabilize that fracture, right? So once you establish that somebody is unstable, you can't irradiate them, and oftentimes they're going to need a procedure. SIN's criteria, I think for most providers, the most important thing is just to recognize the difference between mechanical pain, that movement-related pain that we talked about that gets a 3, versus the non-mechanical pain, that biologic pain, which really should get a 0, but we couldn't talk people out of that, so it gets a 1. The rest of these are really radiographic correlates that are important. So location junctional, like cervicothoracic junction or thoracolumbar, has a higher point score than semi-rigid or rigid spine. Bone lesions are classified as lytic, mixed, or blastic. Alignment, subluxation, translation, the bones aren't aligned, has a very high point score. The degree of vertebral body fracture, collapse, or involvement, and then whether the posterior elements are involved, bilateral, unilateral, or none. These are weighted by the contribution to instability. 0 to 6 is considered stable. So you could have a burst fracture, the whole vertebral body is crushed with no pain, and it's a stable fracture. 7 to 12 is potentially unstable, and greater than 13 is grossly unstable. So what we see a lot of are thoracolumbar burst fractures with a whole lot of pain. Often those SIN score are in that indeterminate or potentially unstable category of 7 to 12. This is the very first patient we saw that we took for this cement augmentation kyphoplasty. He had thoracolumbar lytic bone destruction and fracture, and he couldn't roll over in bed. He couldn't sit up and he couldn't stand. And you all know this well on both sides of the street, because we take a lot of these people for cement augmentations. They put a needle in, they put a balloon, blow up a balloon, and then drip cement in and fill that space. They no longer collapse down when they actually load. There is actually class 1 evidence, a prospective randomized trial, a CAFE study, that shows that kyphoplasty, putting cement into the vertebral body, is significantly better, both at a month and durable out to a year, compared to best medical management. So there is actually extremely good data that this helps in the cancer population. Now, at Cornell particularly, it's much more controversial in the osteoporotic population, where the data in prospective randomized trial does not show a significant difference. But for cancer patients, especially with limited survival, it means a lot to have them up moving as quickly as possible, oftentimes to get back to systemic therapy. It turns out that if you have a burst or compression fracture, here a burst fracture, thoracolumbar junction, with extension into the joint, the posterior elements in the back, you can't do standalone kyphoplasty. You can't put cement into the vertebral body. And that's why Ori and Chris particularly will take these patients. They'll do kyphoplasty at the index level, but then they'll put these percutaneous screws in through the skin and cement them in to give them a posterior tension band to reconstruct the posterior column. We will have a paper on this soon, but our experience was that if you had this situation where you had this fracture, but the back part of the spine was fractured as well, and you did kyphoplasty alone, they did not get better. And so most of those patients will go for percutaneous screws. And it's really the biggest reason that we do these screws through the skin and then kyphoplasty at the index level. And in the early series that we looked at, we really took people from severe pain to mild or no pain postoperatively. And then there are these patients where they have a significant fracture subluxation. So if you look at the posterior laminar lines here, here's C2 way up here, and C1 falls all the way down here. There's about a 6 millimeter gap between the canal space as determined by this posterior laminar line and C1. So that patient went forward like this to fracture subluxation. We don't have really good percutaneous procedures in the cervical spine. So this patient went for an open cervical decompression and fixation. The last issue, right, is how sick are these patients? What's their expected survival? Can they tolerate surgery? Or should you even send them to radiation? And it turned out that in the era of chemotherapy only, we knew almost to the day how long somebody would survive. And then we entered this new era of biologic checkpoint inhibitors, and survival is often used as a determinant as to whether we should offer treatment. With a single checkpoint inhibitor for melanoma, nivolumab, compared to standard chemotherapy, we more than tripled the survival for those patients. And there are 10 other agents that are equally effective for many of the melanoma patients. And so all of a sudden, we had no metrics for how to determine survival. We know that we're doing better in our population, and much of that's due to the biologic checkpoint inhibitors. This was a paper recently that Robbie Rothrock put out from here that showed a 20% improvement in survival over the last 20 years. And again, we think much of that is for the integration of these newer agents which are overall improving survival and responses. It turns out that our really good friends at MGH developed uh, uh, survival nomograms, predictive models that were actually developed in the era of biologic checkpoint inhibitors. So while they don't integrate molecular data, what they do were validated, and was once we already had all of these agents, biologic checkpoint inhibitors, et cetera. The SORG nomogram is online. It's this nomogram, and you can just plug in the numbers, which are readily available in the chart. And I think the intermediate survival is a little bit hard. If somebody's going to live a long time, that's really interesting. But the really critical issue is to find out who's going to survive in that very short term, that 30-day survival, because you don't want to take them for an operation. Even if they look really good, they may be much sicker. And the New England Metastatic Spine score is a very simple score. Both of these, again, have been validated, are much more predictive than the models we had that were developed before we had all these newer agents. Frailty indices are now being developed as well to determine whether a patient can survive surgery, based mostly on sarcopenia and adipose tissue. This is a real effort on John Shin's part at MGH. This has not been validated yet, but these will come online, and then you can have, again, a real metric to determine whether these patients should go to treatment. We do a lot of screening preoperatively, and it's probably infuriating and frustrating that we insist on every patient, if possible, to get a Doppler before we take them to surgery. And that was really predicated on a PE death in a 28-year-old physician who had an epidural catheter placed preoperatively for pain control, got an epidural abscess, was plegic, got operated, and was doing better, and then acutely died of a massive PE. And we thought, on our watch, that should never happen. Like, we should be able to predict that or know that somebody is at risk, and then be able to pre-treat before that happens. And so we initiated a program. We screened Dopplers on surgical patients. We looked at our original little over 300 patients. The incidence of DVT, occult DVT, was 10%. The biggest risk factor, if you are non-ambulatory for more than 3 days or so, there's a 25% risk of DVT. And so for these patients, because we can't anticoagulate them in the perioperative period acutely, we usually wait 2 to 3 weeks. We put IVC filters in all those patients. It is a source of contention with the institution that we never pull those IVC filters out. And the reason we don't is because oftentimes these people are going to be on and off anticoagulation for other procedures. And we don't want to have to put one back in to do another surgery. If they have widely metastatic disease, there's a high probability they're going to go back and forth on procedures. And I think our risk of significant leg swelling and clot up to the filter is probably on the order of 1 to 2%, and it's worth that risk. So we simply don't pull them out unless they're going to be a long-term survival, and they're basically cured of whatever problem there is. There's some other things that may not be very interesting to this group, but it's really interesting in the context of overall cancer care that for oligometastatic disease, so 1 to 5 metastases, used to be that you'd go on systemic therapy or such, or oftentimes people would try to en bloc resect tumors, especially if you had a solitary metastases. It turns out that there are 2 prospective randomized trials. The SABR-COMET trial was a European trial looking at best medical therapy with radiosurgery versus conventional radiation to up to 1 to 5 metastases. And it turned out that if you gave radiosurgery an ablative dose of radiation with best systemic therapy, there was a significant overall survival advantage. It used to be you basically treated symptomatic lesions with radiation, but now you see these asymptomatic small lesions, and people are really getting very aggressive. So sometimes like, why are you irradiating a 2 centimeter met in the middle of a vertebral body with no fracture? The reason we're doing it is we're trying to tap into this overall survival advantage. The PISA trial was actually done here, headed by Mike Zalewski in prostate and Josh Yamada. And this was a bone-only trial. 50% of those patients were spine. We did radiosurgery, either 24 gray single fraction or 30 gray in 3 fractions. And it turned out if we gave an ablative dose of radiation, again, at 24 gray single fraction, there was better local tumor control, which we already knew. What was interesting, though, was that there was a decrease in distant metastases. So giving this local radiation now impacts overall disease burden, distant metastases, and then overall survival. So why is GNOMES important for Memorial and Cornell? Why do you need some kind of an algorithm? It's because particularly at Memorial, we have this volume of patients that if we had to go back and reinvent the wheel with every service, every time we saw them, it would be really, really complicated. This was a 5-day period, 5 days. We saw 62 metastases that were evaluated for treatment. And if you kind of look across the spectrum of what we saw, it's a complicated number of issues, but they're all different. And so we put them into that GNOMES framework so that we make very consistent decisions throughout the spectrum of all those stakeholders who treat. The other reason we're really complicated, even in a cancer hospital, is there's nothing elective about what we take to surgery. So I put this together for the OR, and I just wanted to sort of do this as a mea culpa and why we complicate your lives. But in the start of this was a 7-day period. We had 3 electively booked cases for that week. We ended up seeing 20 in-house or UCC consults that week. And what did we end up with? We ended up with 8 add-ons that nobody anticipated we were going to bring to surgery. And again, many of them were high-grade cord compression. Some of them were infections, et cetera. And so there has to be some leeway. And we're so beyond grateful to the APPs here and certainly across the street for the same issues of being able to get these patients worked up expeditiously. They need medical clearance. They need Dopplers. But realistically, time is spine. And if you give 5 days, sometimes, especially if somebody's subtly myelopathic, you can end up in a really bad place. So how do we make decisions in the GNOMES framework? The neurologic and oncologic considerations, again, are made in combination. From an oncologic perspective, there are radiosensitive tumors to conventional radiation at 30 gray and 10 fractions, principally the hematologic malignancies and then the hormone-driven solid tumor malignancies. The rest of the solid tumor malignancies, colon, non-small cell, thyroid, renal, most of the sarcomas and melanoma, are incredibly radioresistant to 30 gray and 10 fractions. And again, from a neurologic perspective, what we care a lot about, and we'll talk about, is myelopathy and functional radiculopathy, but much of the decision-making is made on degree of cord compression. So at least in 2022, how do we make decisions? Well, for the sensitive and moderately sensitive tumors, regardless of the degree of spinal cord compression, in the absence of myelopathy, we're very comfortable irradiating those patients 30 gray and 10 fractions with the expectation that the tumor will apoptose and decompress the spinal cord. For moderately to highly resistant tumors to conventional radiation with bone only or epidural impingement, we've seen very poor responses to conventional radiation. So those patients go straight to stereotactic radiosurgery. For moderately to highly resistant tumors with high-grade cord compression, you can't conform the beams tightly enough to spare spinal cord tolerance, and they don't do well with conventional radiation. So those patients typically go for separation surgery followed by radiosurgery. What about if we add myelopathy? So they actually come in with signs of spinal cord compression. The only patients we're really comfortable treating in that context are the ones with the exquisitely sensitive tumors, basically the hematologic malignancies, myeloma, and lymphoma. The remainder of the tumors that you won't get a fast enough decompression with radiation alone to get them out of trouble. And so for every solid tumor malignancy with myelopathy and high-grade cord compression, we take them to surgery, followed by radiosurgery. This is probably more applicable, honestly, to Cornell than to Memorial, where you have that patient who comes into the emergency room with no known history of cancer, no known tumor, and they have high-grade cord compression, and they're already myelopathic. And a number of centers will say, we're going to biopsy and wait for the biopsy to know whether it's radiosensitive, and we can irradiate versus not. That's not the right strategy. If they're already myelopathic and they have high-grade cord compression, you do not know what the tumor is, take them to surgery. Why? In part because it doesn't take long, even on high-dose steroids, for them to fall off the cliff. So many times patients who come in, even Asia D, 4 out of 5, within a day or two, or 3, they'll be an AGA, they'll be paralyzed. And you don't want to wait for the pathology to come back to make the determination that you should take them to surgery. So even if it ends up being myeloma, lymphoma, it's the right call. The other problem is it's very hard to make a definitive diagnosis in a short period of time. Here's a patient with sclerotic bone disease and a very high-grade cord compression, and this looks like lymphoma. Unequivocally, this looks like lymphoma radiographically. We did a biopsy day 0, and it ended up being small blue cells that our pathologist said was consistent with lymphoma. Best pathologist in the world said, we think this is lymphoma. We gave an equivalent to conventional radiation, 20 gray and 5. 3 days later, so we're still waiting for the diagnosis. The flow cytometry came back that there was no B or T cell population. So in point of fact, it definitely was not lymphoma. And then it wasn't until 10 days later that it came back a neuroblastic tumor. Now, this patient was not myelopathic when they came in, so we potentially made the right call. But you can see what happened. If they were myelopathic, we have no spinal cord decompression from that radiation. And in point of fact, they would not have gotten better with radiation alone. So the point of fact is they often will acutely decompensate. And 2 is you can't make a definitive diagnosis in timely fashion to get them to appropriate treatment. So simply take them to surgery and then get them treated appropriately afterwards. At Memorial, and I'm not sure about Cornell, we now have a rapid response team. This has been in play for a long time. I think the problem with the RRT at present is that most of the time when it's an acute neurologic emergency, they simply call neurosurgery rather than the RRT. And people get really stuck on spinal cord compression. So if you get a reader of radiographic compression, ESCC 2 or 3, they call an RRT. The RRT is not for cord compression. We see that, 15 times a week where somebody comes in with high-grade cord compression. It's really for acute motor deficit. The big change we made this year is they don't go to CT anymore as first imaging modality. They go to MR, and that's a work in evolution. But this has now been approved by the by clinical council, and it's still being tweaked a little bit. But that's basically how we handle cord compression with motor deficit in the institution is simply to activate a rapid response team. So what do we know about radiosensitivity to that conventional radiation 30 gray and 10? There are radiosensitive tumors. Again, the hematologic malignancies, breast and prostate versus the remainder of the solid tumors are radioresistant. For radiosensitive tumors, we have pretty good control, median durable responses of a year and 2-year local control of about 85%. In the radioresistant tumors, the median durable response in many of these tumors is only 3 months, with 2-year local control overall of 30%. Here's a patient with multiple myeloma with really high-grade cord compression. You can see this is the spinal cord with all this tumor in the canal. Very radiosensitive tumor. We put him on high-dose steroids, gave him 30 gray and 10 fractions. And you can see here the tumor completely apoptosed, decompressing the spinal cord. You can't do better than that with surgery. So oftentimes we'll take these patients, if we know the diagnosis, to radiation alone. The problem is you'll never see these responses in the radioresistant tumors. And for that reason, patients with minimal or no spinal cord compression with radioresistant tumor histologies will typically go straight to radiosurgery. There's a plethora of data on good outcomes using this high dose per fraction radiation for radioresistant tumors. Here's our series of a little over 800 tumors. Again, for those radioresistant tumor histologies with ESCC 0 to 1C, where we had a good target, a median follow-up of a little over 2 years. There were 2 dose categories. There was a low dose cohort with a median dose planning target volume of 16.4 gray versus a high dose 22.4 gray. The only factor significant instance of local failure was a dose of radiation. But in the low dose cohort, remember, we're 70% recurrence at 3 months using ventral radiation. At a year, even in the low dose cohort, we only had a 5% recurrence rate versus a high dose less than 1%. The glory is that these patients are living longer, and that's why the high dose is becoming more important, because as we get out, the low dose cohort starts to fail at 2 and 3 and 4 years, and we're given an ablative dose at 24 gray single fraction. What's also meaningful is that these are both histology and volume independent. Doesn't matter how big the tumor is or whether it's breast or prostate or myeloma lymphoma versus colon non-small cell, we overcome radioresistance with high-dose perfection radiation. That changed our treatment paradigms. This is a patient with a T10 solitary renal cell metastasis. In the old days, using the scoring systems that were traditionally used, like the Tomita and Takahashi score, this would be recommended for an en bloc resection. Take it out as a single piece and try to get margins. These operative times were extensive. Median blood loss was often over 10 liters. And we weren't getting all that good, even local control. With SRS, obviously, treatment times are 20 minutes. There's no blood loss. We have 98% control, and we may get that added advantage of impacting overall survival and distant metastases. Radiosurgery is not without complications, and you definitely see these on the floor. And what we have done over the last 15, 20 years is really try to figure out what those toxicities were and how to mitigate them. The big ones that we see or have seen are really, there's about a 7% risk of esophageal toxicity. And I'll show you how we're trying to manage that now, but we set tighter dose constraints, which help. But you've seen a number of patients, not that many, but they're striking when they come with esophageal perforation, cervicothoracic junction. They get osteodiscitis, and we've had our fair share of those, and we're making efforts to prevent that. Nerve root plexus, you see these patients too. These are the patients that come in with a painful loss of function at about 6 months, and it's a radiation plexitis. It will run a course, but there's no way to sort of make them feel better. Steroids don't help. It looks a lot like claudication. We're now looking at potentially using hyperbaric oxygen as maybe one of the best indications in our population to try to get recovery, but we don't really have a solution. It's only 4% functional neuritis, but it's a really hard complication to deal with. And then the biggest one is to the spinal cord, a core Dmax of 14 gray. We have less than 1% chance of creating myelitis. So we do everything in our power to protect the spinal cord. How do we deal with organs at risk that are in our field that can't take the dose of radiation that we're trying to give? For the bowel, particularly with chordoma in the sacrum, we'll put saline boluses into the retroperitoneum, and we can get the bowel to displace 5 or 10 centimeters from the tumor to create a better target. For the esophagus, I told you we were having a big problem, especially cervicothoracic junction. And now the thoracic surgeons will go in and mobilize the esophagus off of the spine and put a hydrogel spacer there. And that gives us the leeway to be able to treat full dose to the margin of the tumor without impacting the esophagus. Myositis is another one that we've started to see. I don't know if you've seen them or recognize it, but those are those patients who come in about 3 or 4 months after radiation, and they have searing, unremitting, unbelievable pain. It is steroid responsive. But what happens is they get an inflammatory response in the muscles in the field of radiation. Initially, when we saw this, it looked really swollen. It looked like tumor recurrence to us. It does contrast enhance, et cetera. We biopsied it a few times and then realized that this is just a reaction to the muscle. If you put them on steroids, it will settle down. But it's really the toxicity to the spinal cord, trying to treat high-grade cord compression. We can't give those big ablative doses near the spinal cord and spare spinal cord tolerance. And that's really the rationale for taking patients with high-grade cord compression with radio-resistant tumors to surgery followed by radiosurgery. There is prospective randomized data that surgery is better than the only radiation you give in the context of high-grade cord compression, conventional external beam radiation. That was a Patchell study published Lancet in 2005. Again, prospective randomized trial of solid tumors looking at high-grade cord compression with myelopathy, but the myelopathy in their series often was simply biologic back pain. They compared surgery conventional external beam to conventional external beam alone, and they excluded the exquisitely radiosensitive malignancies, the hematologic and then germ cell tumor. In every outcome variable, surgery was better than radiation. And based on this and a number of other studies, the Spinal Oncology Study Group made a strong recommendation that patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression, stabilization, followed by radiation therapy. The question became what kind of surgery and what kind of radiation. And here's a case example of an 86-year-old with papillary thyroid Asia C. there's no way that you can do a gross total resection on this tumor. It's simply not possible. But as we integrated radiosurgery, it became very clear that we didn't need to take out all the tumor. We certainly didn't need to unblock. All we needed to do was create a better target for the radiation, and that became known as separation surgery. We do this, we've done it 3 times this week already at my own practice, but it's really the standard of care now across the world for patients with metastatic disease. And basically all we do is a fusion above and below the area of the decompression. We drill off the bone, we strip out the tumor, we come around the front via a side portal and dissect the tumor off the front of the dura. And all we're really trying to do is take this really high grade cord compression and reconstitute the thecal sac, create that spinal fluid margin, and then we're going to irradiate this. This 86-year-old got recovery of function, underwent 8 grade times 3, fully ambulatory, 2 years out. We gave her a surgery she could tolerate, and then got her to radiosurgery, got local tumor control. In terms of our patients, 75% of our non-ambulatory patients regain the ability to walk, and overall 90% are ambulatory. In terms of patient-reported outcomes, patients do significantly well in terms of pain and general activity. In terms of our local tumor control, if we did aggressive surgery followed by conventional external beam radiation, the local control was only 30% at a year. You can't overcome that radio-resistant tumor histology with conventional radiation. So even if we did really aggressive surgery, gross total resected it or unblocked, if we gave conventional as a postoperative adjuvant, we only had 30% control at a year. This is our initial series of separation surgery followed by radiosurgery in 186 patients. Most were operated for high-grade cord compression with radio-resistant tumor histologies, and 50% had failed prior radiation. 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year Q incidence of recurrence was 16%, but if we gave a high enough dose single fraction, 24 gray, or high-dose hypofractionated, 24 to 30 gray, in 3 fractions as a postoperative adjuvant, we had less than 10% recurrence. And remember, again, compared to aggressive surgery with conventional radiation, was a 70% recurrence rate. We're now under 10%. And again, these responses are tumor histology independent. I'll skip this, but just in light, the renal cells considered incredibly radioresistant. And again, sort of the same population with high-grade cord compression. Our 2-year Q incidence of recurrence is 8%. So this was a series we published this year. So we're now getting very durable control in this patient population. And then here's our non-small cell lung cancer at a median dose of 27 gray and 3. And again, our 2-year Q incidence of recurrence is 5%, again, compared to 70 with more aggressive surgery. So this has largely become the standard. We're making lots of inroads to make separation surgery better in many ways so that we don't put people through traditionally 2 levels above and below. We're now cement augmenting our screws, which makes our construct shorter. So at least in 2022, this decision framework of GNOMES for patients with regardless of the degree of spinal cord compression with radiosensitive tumor histologies will still go to conventional radiation quite often. The exception is breast and prostate with myelopathy. They will go for surgery. For radio-resistant tumors with minimal spinal cord compression, we go straight to radiosurgery. For radio-resistant tumors with high-grade cord compression, with or without myelopathy, we go for this really simple separation surgery followed by radiosurgery. If they're unstable, it's a separate assessment. They need kyphovertebroplasty, PERC screws, or open surgery, and everything is predicated on what they can tolerate from a systemic disease standpoint. And with that, I think I'll end, and hopefully we have just a few minutes for questions.